operative complication, which led into stagnation for the transplant program in the 60s and 70s. And that was due to opportunistic infection that happened in these patients post-immunotherapy, unadjusted immunotherapy, which led into acute and subacute rejection and death. Then the allograft vasculopathy, which happens for all transplanted patients, and among the years of immunosuppressive therapies and steroids that cause such pathology. In addition to all that, the donor selection criteria has been modified thoroughly, and even the cardioplegia was utilized, and addition of DCD and donors and the reperfusion systems that was added, and then pushing the barriers to old elderly patients and patients with coronary artery disease and lower ejection fraction and hypertrophied cardiomyopathy, and utilizing them for as a marginal donors for heart failure patients. Progress in developing pharmacological industries for medications of immunosuppression and addition and removal of certain induction criteria. Surgical techniques, which is Shamway procedure and bicaval anastomosis, has improved the outcome and survival for these patients and diminished the bleeding. How we can prevent CMV, how we can prevent cancer, how we can prevent infection post heart transplant, all that has been modified among all this year, which has led into increased survivals from the late 60s or early 70s until the millennial. And of course, all are dependent on all the medication that I mentioned earlier. The addition of it and the management for the patient with further advanced right heart catheterization and biopsy and adjusting medication over titering the medication. So certain absolute indications that was found for heart transplant is hemodynamic. Absolute indication, of course, is a refractory admission. The same thing, refractory admission due to refractory low cardiac output and end-organ perfusion, and also due to acute cardiogenic shock. Of course, the data has classified these as a high-risk transplant versus the one who are elective and stable on medication controlled and just called simply after founding a heart for them. The dependence of inotropic supports as the risk, and it is an indication. The presence of MCS is an absolute indication if it's the patient is not having any further contraindication for heart transplantation, such as HIV or age. Once the peak VO2 is less than 10, that's considered very incompatible with life. The patient will not survive, so we really need to transplant him. Of course, all sort of classification, grade 4 New York Heart Association, dyspnea and orthopnea and PND and ascites and edema and pulmonary edema and lower lymphedema. All that is an absolute indication for the patient. As I mentioned, malignant ventricular tachyarrhythmias are an absolute indication. Pulmonary hypertension. So two types of pulmonary hypertension, the reversible and irreversible. The reversible one is, of course, a patient taken to right heart cath and gets several reading, gets tracing for all his PA, systolic, diastolic, and mean with the TPG, with the end left atrial pressures and ventricular pressures and right pressures. And we manage them and divide them and deduct numbers and try to get the wedge and try to get the TPG and try to get the PAP index pressure. the PVR, and then once all these are noted, we do condition 2, which is putting testing the patient with nitric oxide, testing the patient in presence of milrinone or dobutamine or dopamine or prostaglandins. So any sort of pulmonary vascular dilatator or dilating agents are utilized to see if there is some flexibility in the PA pressure and it's dropping down. Then this is a good sign and the patient is eligible for heart transplantation. However, when they have an irreversible pulmonary hypertension, despite whatever we do as the condition 1, 2, 3 in the right heart cath, with persistence, high TPG and mean, which is the mean transpulmonary gradient, and the pulmonary resistance PVR, and the PAP pressure, which its index is low and it's high, the PA pressure, then this is a patient with a fixed pulmonary hypertension. And if you put the Superman's heart in him, the lung will definitely kill this new heart, or kill at least the right ventricle. So what are solution for such patients? Please refer them early. That's the solution. We can be sometimes heroic and put LVAD for them. Some of them can flex their vasculature, pulmonary vasculature, and become reversible PVH, and some others remain and it becomes as a destination therapy. Sometimes even when you put the LVAD, you still have a lot of resistance in the capillaries, where you're unable to transfer the blood from the right to the left side, and the left ventricle assist device will not function, because you will definitely have a low volume in the left side, and suck down events and phenomenon is going to start to happening, inducing arrhythmias, inducing thrombus, inducing hypotension severe. So even an LVAD cannot fix this fixed pulmonary hypertension. Absolute contraindication, systemic illness with these patients who are having HIV positive, who are having AIDS, which is uncontrolled HIV. I mean, some patients receive some transplant organ like kidneys and liver who are HIV, but it's still not a waived indication or waived contraindication. In many centers, way more than 95% do not do these patients, even cirrhotic livers and HBV and HCV. In patients who are elderly and above expected life expectancy of less than 2 years, these patients don't get to be on the list. Patients who are, before we were transplanting up to 60 years of age and 55. When I joined King Faisal, we were doing 50 or less. Now we do 68, and that's, I believe, the highest number, or 69 we have done. A few years ago in 2011, when Dick Cheney was VADed at the age of 70, it was a huge story, and with many controversies, and people are attacking, the press are attacking the government, and people are attacking the US government of how could you do such a thing, because it's very obvious that this has been biased decision. And then 2 years later, he was transplanted at the age of 72 and a half, 73, which even created further animosity between the UNOS, which is the National Organ Transplant Committee, and cardiac surgeons in the United States. So WASTA is present in every single country worldwide, regardless of their bureaucracies and democracies and vote and nomination. So just to let you know, and this was a huge animosity. However, it did happen. Nowadays, 70 years of age, some of them gets a heart transplant, but you're still limited because you have a 25 years of age who's in need of the same heart. And further systemic diseases such as Marfan. Marfan disease, when it is very systemic, that is causing abdominal aortic dilatation, aneurysms in the lower limb, in the upper limb, in the gut, in the organs of the abdomen, in the organs of the chest, and in the cerebral. You don't do these patients, and you don't really change the whole thing. So you just give them the cardiac surgery, heart failure that you can do, and CRTD, and that's it. Um, some centers are implanting an LVAD for them, and even with the LVAD implantation, we all know that once you do an injury to a marfanoid vessel, there will be a pseudoaneurysms and an aneurysms, aneurysmal sacs folding around the anastomosis. So we're really careful with these patients. Systemic lupus, amyloidosis, sarcoidosis, all these are some of these systemic is multi-organ failure, which is irreversible multi-organ failure, from liver to kidney, and that is not cardiorenal syndrome or cardiohepatic syndrome. Then you really choosing heart transplant for these patients. Of course, when you have a severe COPD, irreversible COPD, advanced COPD, these are patients who do not get listed. Diagnosis of heart transplantation according to ISHLT. The majority of these patients are cardiomyopathies, and majority of them are non-ischemic cardiomyopathies, which is mainly dilated cardiomyopathies. Some are ischemic, which is due to the coronary artery disease. Minorities, you find congenital 2%, transplant 2%, and miscellaneous, whether it is postpartum or chemotherapy or valvular, which is varying between 1 to 3%. Between 50 to even 70% of these patients. Age advancement I'm sorry, just 1 second here. I have to take this call. Hello, I'm sorry, I'm in a meeting. Can I? Anyway, donor and recipient selection. So basically, in a heart transplant program, it's a very big field, and it's not about guidelines, and it's not about indication and contraindication. It's really dissecting case by case. Of course, knowing your limitation and the indication and absolute contraindication sort of give you a limitation between whether you cannot do or whether you can do. I might need to accelerate this lecture. Again, so the donor and recipient selection, what kind of donors, what kind of recipient, that's a huge topic. In short, donors have to be in good health, have to be below the age of 40, have to be matching with ABO, the matching with the size, matching with the gender, the sex. No one will ever know what's the age or race or ethnic or location from the donor. That's not allowed by the government. We cannot tell, and that's international law. Whoever does the transplant is not allowed to even attend an transplantation. You are not allowed to otherwise you're going to be pursued by law. applicable here at King, because some people says, I don't want female heart, I don't want an Indian heart, I don't want a Chinese heart, I don't want a Christian heart, I don't want a black person's heart, a white person's heart, a yellow person's heart. And so you're not allowed to mention that. So you have to know this. Some marginal donors are utilized, and marginal donors definition is quite broadened. Simply the age of 35 it used to be, pushed to 40, 45 now, and above, someone who has single vessel disease, someone who has low ejection fraction between 35 and 50, someone who has hypertrophied septum with septum above 11, 12 millimeter, reaching 14, 15, and these patients are called marginal donors. Someone who is having an infection during donation of organ, a malignant infection, someone who has an HCV or HBV. HBV is basita. You can vaccine the recipient and vaccine him and boost him up. HCV is really dependent on the recipient. If he is a marginal donor, should go for marginal recipient. If someone is dying, and you still need to talk to the recipient and consent him for this. Contraindication for donation for these are significant heart dysfunction, so it's less than 30% in an elderly. You can accept 35 in someone who is 25 years old, because there is a reason for the 35% ejection fraction. It could be a car accident, it could be mismanagement of the donor, a lot of volume, less volume, give or take. It could be a hit, an accident, or just a head-on collision where there is a huge trauma to the chest and to the RV that caused this thing. It could be due to many things, and it could be to single vessel disease, LAD, RCA. You can do a bypass to that vessel, and you can do the transplantation. Transmittable diseases, I mentioned it. Malignancies, I also mentioned it. And of course, if you accept for malignancy, you have to make sure that there is a low metastatic chance of this cancer. Matching the donor to the recipient, weight, height. We take the height very seriously, because the weight varies if someone is changing his weight due to heart failure versus due to his love to food. So height is considered more, but the weight is definitely considered, and you should not bypass the having a mismatch above 23%. We at King Faisal, we're very, very, I don't know the word, I would call it brave, or I would call it crazy, because we do reach 35%, but out of frustration, because we see the patient dying, and we have to help him. And we have to make sure that this heart does not have any other recipient to take. So it's either going to waste, or either going to this obese patient who is 125 or 121 kilogram. At that time, we have certain modalities that we do, and we follow certain techniques to ensure the survival of this heart, new heart. So body size compatibility and mismatches has to be looked into it, and of course, hemocompatibility and sensitization of the heart. Whether is it broadly, whether is it widely sensitized. We look at the CD3 and 4, and we look at the PSR, and we look at so many things to dig deep. This is something that's taken with the pathologist who is a transplant pathologist, and very thorough in his testing. As mentioned here, is 20% height and weight difference. It's by liters is 23%. We have gone above 33%, and the outcome varies as well. Male to female, so female always being given to female. Female should be given to a smaller size male than her. Otherwise, a male for female is easy, a male to male is an absolute. Surgical techniques, it's the usual thing. Um, uh, uh, um, and of course, heterotopic is never been done. This one, I mean, after the 70s and 80s, it's always orthotopic, and it's always a bicaval technique, chamois technique, which is what you've seen here, and it has improved from the previous one here. The immunotherapy, that's a very deep and subspecialized topic. I don't think that you will benefit a lot, but we do, just in brief, we do an induction therapy for the patient, and day 1 or 2 for it could be 1 dose, single dose, or 3 doses ATG, and then we start the immunosuppressants such as prednisone, and then tacrolimus. Most of the time, we can add sirolimus if there is a kidney injury or CKD disease, and we have to make sure and protect the body. Sirolimus is known to have allergy and stuff. We make sure, and gallstones it cause, and it cause lots of other things, and it's a very expensive drug. So we have to do further testing prior to choosing that one, but to protect the kidney as well, since immunosuppressants are very harmful to the kidney and liver. So we talked about that, to desensitize the patient. Part of patients are very highly sensitized, and some rejection might happen. Plasmapheresis is there. We do intraoperatively plasmapheresis. We do postoperatively plasmapheresis. We do preoperatively plasmapheresis to um, make sure that the levels of the rejection rate, which is classified into R0, 1, 2, 3. R0 is almost never happen, because R0 is that means it's you took an organ from your own body. However, R1 is the one you see, which is almost 85 to 90% of the people population in a very advanced center, very advanced heart transplant center. That's what you see. Our rate at King Faisal is 91% R1. We have 6% R2, and we have around 2.8% is R3. And R2, you repeat further biopsies. R1, you ignore it and you do it every طبعا لنا rhythm معين after transplant. In the beginning, it's often, and then it becomes every month, then it becomes every year after the first couple of years when everything is negative, or R1. R2, we have to follow it thoroughly and probably adjust the medication, tacrolimus and cyclosporin, into certain levels that we want it. If it proceeds into R3, then at that time, red alarm, and we have to MMF again, and we have to increase prednisone, and we have to even sometimes advance and go into plasmapheresis and IVIG therapy, and then we even go further aggressive and put the patients on ECMO for a while until we treat the acute subacute rejection. Chronic rejection, of course, acute and chronic are different. It's a humoral versus cellular. This is really quite advanced. These are talked about, which is 0, arm 2, 3, which is mild, moderate, severe. And I don't think I should go through all these, because these are quite advanced. These are mainly for the heart failure cardiologists and immunologists to talk about them. But I just wanted to talk about the infection. Infection is really, I mean, transplant. It's a problem, and CMV is a major problem, because we know that CMV is a cytomegalovirus. It stays forever, and it can lead into many causes, including skin cancer. So we have to be very careful while monitoring the infection rate, and sometimes fungus. You get patients coming out to you with plaque, white patches all over your body, and you have to treat that. In transplant vasculopathy, we really need to do coronary angiogram. Not a lot of people or centers does the coronary angiogram to follow up these patients. and especially after being transplanted for so many years. But if you do them and you suspect something, do an IVUS, a pressure wire, to measure the intimal thickness, and that will conclude the vasculopathy. Let me see. This should function. This video should function. This video is a coronary angiogram that was done. So just to let you know, this is basic. غريب. This is simply all the coronaries. We know it's between 1.25 to 2.5 or 3 millimeters. It becomes a thread. It becomes like a thin hair thread, less than half a millimeter coronaries. Sad, they're not working. So they become very, very thin coronaries, and simply ischemic cardiomyopathy again, and you have to retransplant, which we have done retransplant, and we have done. We're one of probably 3 centers in the world who VADed VAD put in a retransplanted heart, and retransplanted that VAD that was put on the retransplanted heart. So it was a beautiful nightmare. Transplant vasculopathies, you have to do an aggressive management for the risk factors, whether it's dyslipidemia, whether it is the rejection that he's having, cause of rejection, bad control of medication, non-compliance by the patient. Do we need to have atorvastatins or pravastatins or any kind of statins added into the medication to lower the equation of vasculopathy? Retransplant is something to be looked into it and measured. Again, these are quite advanced, or I would say you guys are quite advanced right now. Infections, variety of infections. I want to say the fungal and medication, and you of course corticosteroids can induce that a lot, so you have to have antimicrobial medication. What is the leading cause of death is malignancy. Why? Because you immunosuppress these patients, and yeah, we all know immunosuppressed patients get malignancy. Look at HIV patients, got a new malignancy that's called what's it called? I forgot that. Sarcoma, that kind of sarcoma.
Kaposi sarcoma.
Kaposi sarcoma.
Kaposi sarcoma.
So Kaposi sarcoma, it was discovered from the HIV patient. A lot of the HCV and HBV patients are getting Kaposi sarcoma. A lot of patients are getting Kaposi sarcoma. So it is due to the immunosuppressants. Transplant is not an easy way. Freedom of malignancy. You have to know malignancy happens. Also, it's higher in sick patients. Patients who goes to transplant who are intermax 1 and 2 and 3, inotropic dependent, ECMO, balloon pump, MCS, LVAD, reoperated, received a lot of blood transfusion, been ventilated for a long time. So all sort of comorbidities that can happen perioperatively or preoperatively is considered to be an independent risk factor for mortality in a heart transplant patient. The most common malignancy I wanted to mention is a skin malignancy, melanomas and all sorts of melanomas. And King Faisal, we're about to publish a paper which is our malignancies. We have seen squamous cell carcinoma in the stomach, and we have treated that patient. with surgery and resection and radiotherapy, and he's still that patient. This patient, I put him 10 years ago or 9 years ago. A year later, he got cancer and then treated and got surgery, and he was home and still living. We have one a non-Hodgkin lymphoma or B-cell lymphoma. B-cell lymphoma. So it's really low percentage of malignancies and high percentage of freedom from it. These are certain, just to show you that the types of malignancies and which one is more and which one is less, and how we treat each. I don't want to go into these things. Renal failure post-transplantation is increased by sicker patients and elderly patients. The stage is the worse the outcome, or the higher the rate of renal. Of course, hypoalbuminemia and as was an independent risk factor for acute renal failure. And of course, in a bypass, because its MAP goes down to 40 and 50, because it's a continuous flow, because we talked about it, that end organ loves pulsatile flow. And when a patient has CKD type 3, stage 3, then he is he's going to be pushed to stage 4 and stage 5, and then dialysis. Chronic renal failure is increased with diabetes again, because of the nephropathy and the age and of course the status of the RV function, because we all know RV is connected to the kidney. You have why kidney? That's a question you're going to have in the board. Raised RV pressure due to RV failure is raising the right atrial pressure due to stagnation and raising in the end diastolic volume in the RV. Dilated RA, more RA pressure, backflows into IVC and SVC. Congested liver, backflow into the renal vein, the perfusion pressure when you have a heart failure patients and have systolic of 70, 80 and diastolic of 40 with mean of 45, you have, or 50 maximum, you have a right atrium pressure of 25. So you only perfusion pressure to the kidney. We all know that the kidney needs 60 perfusion pressure. So you lower your right atrial pressure, you increase your afterload pressure to make sure that the kidney is perfused, and so on. So this is how it is, the vicious cycle where the RV is connected to the renal function, and hence causing cardiorenal syndrome and worsening outcome post-transplantation or post-bypass. Of course, patients who are sensitized with their autoimmune, with immunity and HLA and CD4 and resistance or some sort of rejection can cause the chronic renal failure, and you need to really think twice of when to start immunosuppressant and what kind of immunosuppressants you're going to start. So again, this is causing and I wouldn't really waste. When you look at the hyperlipidemia, you look at the diabetes, and all this is a risk factor to cause acute or subacute focus on this one, avoid NSAIDs. So, because this topic needs a week of lecture, not an hour. you need to in heart transplanted patient because of the and some sort of malfunction. You need to be careful. And NSAIDs, you cannot take these medications. Steroids, you need it, but you titrate it according to the rate of rejection or classification of rejection. Furthermore, into that, I mean, vitamin D, vitamin D, vitamin K, calcium levels has to be studied. Osteoporosis are being, as a matter of fact, discovered for the past 10 years only. And more, and coronary vasculopathy, and should we, in these transplanted, not to eat red meat and focus on the white meat, especially under investigation. All has been studied, and even us at King Faisal, we are studying the radiation and its effect on the heart, the even chest X-rays, the rate of biopsies, the rate of following vitamin D, vitamin K, calcium level, phosphorus, zinc, all that to look into it and make sure that it is in the normal range, so it can. Population has worsened survivor rate. It has, but also of that with advanced therapies has improved the survival rate. So we should really be reaching the 95 and 100%, but we are at 90% of survival due to the advanced age, due to the advanced complexities and comorbidities and the redos and the VADs. I mean, the VAD is not really a good thing. You think it can improve patients' life. It does on the short term. We don't know what does it do for the 5, 10, 15 years period of support. I mean, of transplanting the supported heart and their outcome. It's not a good thing. And every VADed heart is not equal to a fresh heart. And it has been proven. So we don't know if we are seriously doing the right track, and that's why coming back to you and telling you, please do not do Intermax 4, 5, 6, 7 to VAD them, because you are a favor to the company. I like companies because they do a lot of R&Ds, but I don't like them when they start to talk numbers to us, not looking at patient care. And believe it or not, every single company is that, because it's an era of capitalism. So these are the transplant survival at 1 year and at 15 year. It's this is the ISHLT database, and it is equal to King Faisal. As a matter of fact, we are 3% higher than the ISHLT, despite the fact that we have a very high risk patients. But the reason why this higher survival we're having, because it is the way it should be. It's centralized, not so you will dilute. A center should do 20 and above. A center with a respected experience. Doing 1 to 5 a year, you're really not doing good to the patient. And if you open more than 2, 3 centers, you're gonna end up by having 5 each, and you're gonna end up by having a national should go to one hospital, that should go, orthopedics should go to another hospital, and that's centralized. They have said that, and he is the first heart transplant surgeon in heart or orthopedic heart into a pediatric age. And him at Parents Alternative Center, he wasn't really so keen to push further. And now he's opening other centers, and he is against transplantation to be a patient. He believes in centralization. And that's where you get the fantastic outcome. Having a patient here in stage 4, stage D heart failure, having half of them living at the age of 15 years due to this transplant, it's a huge, other gets or VADed post-transplant. So we give an opportunity to a patient to live. Again, just simply a comparison between certain age groups and their outcome, the recipients, the donors. All these are way too advanced, and it's not.
Dr. Feras?
I'm done, yeah, Haytham, go ahead.
Because it was interrupting the internet. This is the...
Hello?
Hello? Yes, now you hear me.
You guys were not hearing me? I've been talking nonstop for the past... You did not hear what I'm... Hello?
Yes.
There, but the last 1 or 2 minutes, it would be better because not clear. 1 or 2 minutes back.
So only 1 or 2 minutes you did not hear me?
Yes. Only 1 or 2 minutes.
Yes, almost. This is
which minute? Which minutes?
The last, maybe the last 3 slides.
with the opening multiple centers for transplant.
Yes.
We cannot hear you now as well.
Okay, forget about it. Hello?
Yes.
Okay, I'm pretty much done. So what I'm saying is the last advice for you is you need to subspecialize, and you need to pick a specialty you like, because this is where the era is going right now. And hence the centralization that I was talking about. I'm done. Thank you.
Clear. Thank you very much, Dr. Feras. Any from the floor, any question to Dr. Feras?
Thank you.
I have a question, yeah, Haytham.
Yes.
Have you guys sat together and discussed who wants to subspecialize and where they want to subspecialize and what about to subspecialize? Because this is something extremely crucial, especially at your level now being R6 and R7. Even from R5, you need to start going there because R4 is the one when you enter cardiac surgery. So did you start looking at a 47 years old male with cardiac cachexia? Like the usual patient comes to you. He's got biventricular failure with dilated cardiomyopathy and reaching intermax 2 as becoming dependent on double inotropic support, declining end organ perfusion. Right heart catheterization showed severe pulmonary hypertension with raised capillary filling pressure and wedge pressure not responding to nitric oxide. So it's becoming really fixed. And he is continuously deteriorating despite the inotropic support. He is having a decline in blood pressure, having systolic pressure of 60, diastolic of 30, 45 mean pressure, really basically pre-arrest condition. What do you do?
This patient has indication for transplant, and same time he has contraindication for transplant, as pulmonary vascular resistance is to pulmonary hypertension. I need to get the pulmonary vascular resistance and if it's reversible with the vasodilator or not.
So I don't like the statement of he is indicated to transplant and not indicated to transplant. It's either whether he is or he's not. Both together does not exist in heart failure. You want to say he is a heart failure, he is an end-stage heart failure, that I would accept, but he is an indicated transplant, that's not correct. And because I gave you between the lines, I have given you one absolute contraindication, which is irreversible PVR. And that was the trick in here. So should we try to add a third inotropic support for this patient, or should we wait for him to improve with IV diuresis? What should we do? I don't know what to do. You don't know him. You have never done HLA typing. You have no idea if he is eligible or not for transplant. So you don't know, but you have an absolute contraindication. So what do you want to do?
I think I'm gonna proceed with the mechanical support with BiVAD because he's having a biventricular failure.
So what do you want to do, Uthman?
I want to get him out from this status from Intermac 1.
How are you gonna do that?
I will implant biventricular or BiVAD for him.
Okay, that's acceptable. What else?
I think initially I will start with the medical therapy, inotropic supports. If that it is if he's requiring high inotropic support, I will shift for ECMO, bridge to decision. Then I will see how he will respond to the ECMO plus intra-aortic balloon pump.
Or BiVAD as destination therapy.
But I don't know, maybe BiVAD permanent and I need something temporary, I think so.
لا تتكلم متخبص. هي اسكت.
صوتك دكتور.
You give one answer which is the perfect answer. A permanent thing, you don't do it for this guy. Why? He has already congested liver. He will bleed to death if you put an BiVAD permanent one. You need to stabilize him. So ECMO is the choice. Prior to ECMO, prior to the BiVAD, I will think of a balloon. Why hasn't anyone talked about the balloon? We talked about the balloon. The balloon is the least invasive. The aortic valve open. And if the aortic valve open, that means emptying the LV, and emptying LV means emptying LA, and emptying LA means no pulmonary edema. So that's a very good combination, balloon pump.
By that, I would go for a non-durable device by that. So I can put, but why do you want to cut so many places? Why do you want to cut the P? You want to go, I think what you meant is eventually heart transplant, but no, it's a bridge decision. You need to make sure that this patient, you need to do a right heart cath. You need to advance him. You're gonna promote after an ECMO for a while and you reperfuse everything. What I would do is if after a while the PVR corresponded, if right heart cath reading. So what I do is either impella or I convert a good RV function or MOD. When I decongest him, dry him out, I will upgrade him in there. Because usually biventricular failure is RV failure caused because of LV failure. And if you can optimize the patient, you might get away with VAD alone with the proper management. That's for the patient. Fine.
So, Doctor, sorry, there was a problem with the internet. So basically, we escalate from intra-aortic balloon pump, work him up, and then VADS, and then transplant if responded.
Like 10 hours, one day. If he is still on low flow, you have to intervene with ECMO immediately. If he improves his systolic pressure, then you calm your horses, observe the end organ perfusion by looking at the creatinine, looking at the urea, looking at the GFR, looking at, because usually the kidney gives you signs. Liver, it gets the hit and stays sick for a while. The kidney is going to tell you, hello, I'm doing fine. And also the oxygen venous saturation or mixed venous saturation, because you have a right-sided swine gans or central line where it can gives you an idea of how is the mixed venous sat is. Am I answering your question, yeah, Doctor?
Yes, يعطيك العافية.
Allah yafik. Second patient. So all these are diagnosed and found out in this patient. He got listed and he received a heart. After a few months or years, let's say a couple of years, he got acute cellular rejection, and he was responded into the treatment, and he again got another rejection, and it was R2+. So he got on the anti-rejection treatment plus the IVIG and plasmapheresis and repeating the same therapy. So further medication, ACE inhibitors, beta blockers, diuresis started. However, he further developed into deterioration of his LV function, and he was found out by the coronary angio that he's got a thickened intimal wall in the coronaries caused by its immunovasculopathy. So he got listed for retransplantation. But the patient is highly and broadly sensitized. The kidneys start to shout for help. What do you do?
So initially, I think if the kidney and the inotropic support is not working, I need to think about the mechanical first medical therapy with him to support him. And if that not working, we'll go to the intra-aortic balloon pump to help him more. Then I have temporary device that need to be used like ECMO. Then I will need to see what's the time he needed to be listed in the transplant to change my plan, either to shift him to the LVAD in top of his transplanted heart, or that I can do the transplant in near future. And I need also to work him regarding, do for him desensitization by plasmapheresis and all the medical therapy for that as well.
But all what you've mentioned, it's already done, except for the ECMO and non-durable devices and balloon pump. So anyone else answers before I answer, Haytham? I need more people answering. It seems like I have only 3 audience in here.
We evaluate him if he as part of what Haytham said, when the transplant will be done, we can put him in temporary LVAD, or even we can put him in long term LVAD till he get the new heart.
Okay. Who else is going to answer? Guys, you have to interact, because I have spent 5 hours with you. I need the other residents to interact. You can give me any answer. There's no stupid answer as an answer.
I think total artificial heart will be a choice for this patient.
Okay. Other than the 3 residents who are being very interactive.
Yeah, it seems, as Osman said, I think also the total artificial heart is a good option for him.
Type. What we do for this patient is I accept the total artificial heart. I don't accept the temporary support, whether it's a balloon or anything else. The patient is deteriorating. You need to list him for the transplantation. And if the biventricular failure, yes, you can have total artificial heart. It's going to be a nightmare as a redo, but you have to do it, especially a redo post-transplantation, because the immunosuppressants gets the tissue further adhesive and stuck to each other. You can LVAD him, or you can BIVAD him, or you can transplant him. That is the proper answer.
But I have kindly, Dr. Feras, now I have a quick question. Why ECMO is not an option here?
Because you're bridging him to what, Haytham? What are you bridging him to?
Okay. So now I get it. Now I get it, because I have a clear pathology, and I know my path for him. There is no decision.
Exactly. He's not an acute cardiogenic shock. He's chronic, because this vasculopathy is a chronic thing. So you don't put an acute treatment for a chronic thing. You know, you still have some time to support him with the inotropes, with medication, and until you get him a heart as an urgent transplant. This is the super urgent transplant we call type A, or you get him a VAD, a permanent VAD.
Yeah, now it's clear, because before I was having a confusion between these, but thank you for this scenario.
No
now
problem.
It's clear. Thank you.
Case 3, an 18 years old with dilated cardiomyopathy, is cachectic. He completely lost his muscle mass. He's got multi-organ failure. He's got systemic pulmonary hypertension. He went into Intermax 3, then 2, then 1, and then cardiogenic shock. And that is the patient. So he is, because of his cardiogenic shock, he has an ECMO insertion to perfuse his end organ function. What do you do for this patient?
So I think that تفضل حسين.
تفضل.
So initially he came in cardiogenic shock. At that time, he needed an ECMO as a short-term mechanical support. After that, he's cachectic. He had, I saw in the slide, systemic pulmonary hypertension. Maybe that due to his left-sided heart dysfunction. Yes, so systemic pulmonary hypertension and cardiogenic shock. So after the ECMO, I need to see where he will go and to test this pulmonary hypertension. Also, his cachectic. I need to work on the nutritional status of this patient. Then I will prepare him either for transplant or according to the pulmonary according, is it reversible or not reversible pulmonary hypertension? If it is reversible, that means either he will be listed for LVAD or he will go to the transplant according to the availability of transplant. Also, there is a good things about the LVAD that because he's cachectic, so that it will give me time for him for nutritional support. Then I will list him for the transplant. Because cachectic, going for transplant, this calling for a problem for him.
Very good comment. Anyone else?
I agree with Haytham, except the patient having pulmonary hypertension, I will not go for LVAD alone. I will go for BiVAD.
No, but initial this is systemic pulmonary hypertension at time of cardiogenic shock. Maybe I'm wrong. I'm just discussing. And at the time, if I give him ECMO, because I don't know what's the underlying pathology, many of them, because of the left-sided, they have a problem. If in the ECMO not improving, not reversible, I said at that time, yes, biventricular. Agree with you.
So if he improved, he will go.
I disagree with the BiVAD because you don't know if it's going to be reversible. If you put a BiVAD, you increase the mortality by 50%. So you have to be careful in which patient receiving BiVAD or not. And this patient, I agree that if he goes cardiac cachectic into transplantation, it has a lower survival rate at immediately and at a longer duration. However, you go for heart transplant. You revive him on an ECMO for a week, a month or two. You revive him. You need to transfer the peripheral ECMO into central ECMO after stabilizing him. The point here I want to show you is acute cardiogenic shock, put a heart extracorporeal membranous oxygenation in him peripherally or centrally. And I prefer always peripherally to avoid the bleeding because the liver is always congested, the INR is always 4 and above. And then you upgrade it if needed, if he's prolonged. If not, then keep it and wait for a heart and hope for the best. I wouldn't, if I prolong the ECMO above a certain period, and I mean certain period, I didn't want to put a day, because ECMO sends you signs that it's time to remove me. Thrombus, clotting, fibrin, pulmonary edema, etc., etc. So at that time, you have to move. And when you interact, you need to upgrade it or put a vent or simply, I mentioned to you guys, you convert the ECMO into an LVAD to test the RV, because you cannot put a right heart cath in an ECMO patient because it gives you bad reading. So you don't know if it's reversible or irreversible pulmonary hypertension. So you need to test that. By testing that is putting an LVAD, temporary LVAD, and the same ECMO, you just change the cannula into the right superior vein, do a temporary LVAD, do all your testing, the right heart cath and testing the right ventricular function after a week or 10 days, emptying further the patient, seeing how it is, and then you can go into an LVAD, permanent LVAD, only if he is blood group O, only if you fail to find a heart for him. We were lucky, we found a heart and we implanted it about 5 weeks, 6 weeks later. And then we did do an extensive physiotherapy. And yes, Haytham, the patient needed a thorough physiotherapy and stayed 5 months in the hospital until he got, you saw him before. He's a skin and bone kind of guy. And that's how he looked like.
So that's what MC is all about. So I'm gonna stop right here, and I'm gonna thank you all for listening. And if anyone has any question, then we can schedule something else at another time without a problem. Okay?
Okay.
All right. Thank you once again.
Regarding more question.
Yes, Uthman.
If I have a patient who is have an acute heart failure and then placed on ECMO, and now is more than 1 month or 2 months on ECMO, he's doing fine, but there is mild fungal infection. Shall I proceed with LVAD or transplant, or just keep her on the same
you treat the fungal and you proceed.
Okay.
For a transplant, if there is a heart and he's stable for transplant, you proceed and you transplant him. If he's unstable and it has been a while since he's been on ECMO, then you have to upgrade it. If he has only left ventricular dysfunction, then you go ahead with an LVAD. If he has both, then you go ahead with a BiVAD. Again, you go ahead once the ECMO starts to give you signs, and usually starts after 14 days. So you need to evaluate according to the situation that it's presented to you.
Okay, thank you.
Thank you, guys.
Thank you very much, Dr. Feras. Really appreciating your time, you spending your time with us and all this explanation. And also one thing, this lecture, it's been recorded.